Hi everyone, my name is Oliver Rivera. I'm a physical therapist from Chicago, Illinois, and today we're going to be talking about some physical therapy considerations for the adaptive athlete. Here are today's objectives. We're just going to go over a variety of adaptive sports and some different classification systems. We're going to talk about injury in adaptive sport, some considerations for the adaptive athletes. We'll review some specifics on wheelchair sport, as well as the lower extremity prosthesis that you probably haven't seen since PT school. And then we'll kind of briefly talk about some return to sport considerations for this population. So just some background on me. I graduated from University of Illinois in 2012. I did my DPT out in Las Vegas at Torrey University, finishing in 2017. I did the orthopedic residency at UIC, finishing in 2018, and I got my OCS the following year. I then worked at Shirley Ryan Ability Lab for about 5-6 years in their adaptive sport and fitness center, primarily working with orthopedic patients with pain, but were more of that neuro population, and then as well as a variety of athletes, including able-bodied and adaptive athletes. I was in the first class of Northwestern University's Fellowship in Advanced Orthopedic Physical Therapy Practice, Research, and Education, their Manual Therapy Fellowship. And then working at Shirley Ryan Ability Lab, I was able to work with adaptive golfers as well as our sled hockey team, and that allowed me to sit for my SCS in 2023. For the past couple years, I've been working at University of Illinois Chicago, treating patients in our faculty practice, serving as a mentor in our sports residency, and then assisting in the DPT program in the MSK series. So this is me. I'm kind of over on the left, right underneath the gentleman in the gray hoodie. I think this was in 2022. We played a little scrimmage, physicians, physical therapists, and then our sled hockey team at the Fifth Third Arena in Chicago. And this is how I got my start in adaptive sport, being a PT for this team, where I would help out any of the athletes with any injuries they had, as well as gave the team some general exercise to uh, uh, promote injury prevention. And then I got even more experience in adaptive sport when I was selected to assist the USGA with their inaugural US Adaptive Open Championship. So at Shirley Ryan, one of the physicians is a big proponent of adaptive sport and is partnered with EDGA, which is the European Disabled Golfers Association. He trained me to be one of the medical assessors, and then I assisted him in the medical screening of all the golfers that applied to be part of the USGA's initial Adaptive Open Championship. So I kind of screened out each golfer, ensuring that they qualified for EDGA's WR4GT pass, meaning that they met EDGA's requirements to um, collect world ranking points in any adaptive golf event that they participated in. So the USGA used this system to ensure that all golfers met a certain criteria to be able to participate. Um, so in my in-person talk with this, we'll usually review about like what are your current perceptions and experiences with adaptive sport and adaptive athletes, as well as what are your current misconceptions. I think there's a lot of uh, thoughts about that adaptive athletes are primarily like wheelchair users or lower extremity prosthetic users. Um, but really, it can be anybody that has a certain condition that affects their way to participate in able-bodied sport. So for adaptive golf, for example, we have players that not only use the prosthesis for the leg or the arm, but also have blind golfers, golfers with intellectual disabilities. So really, an adaptive athlete can be anybody that may have to modify the way they perform their sport. And the best thing about adaptive sports is that it really highlights the ability of individuals versus having people think about the disability of that individual. So let's take a little look at kind of what's out there in terms of adaptive sport. So this article looked at the different adaptive sports that were included in the Paralympics, from the first Paralympic event in Rome in 1960 to the 2016 and 2018 Summer and Winter Olympics in Brazil and then Korea. So you can see that there are a lot more sports included in our more recent Summer Olympics in 2016 compared to that first one back in Rome in the 60s. For the seated athlete in adaptive sport, you can see that we have our typical wheelchair basketball, wheelchair rugby, but then there's also fencing, there's track, tennis, and golf. In terms of prosthetic users, you can compete in track, in golf, in weightlifting, and archery. And then there are even non-prosthetic users still participating in these sports. Um, so a single limb golfer without a prosthesis, just because that's what they're more comfortable with. This individual here, I believe he's out of Canada. I forget his name now, but he is he at least was the number one ranked single or one-arm golfer in the world back in 2023. So he chooses to not use the prosthesis on his right side to aid in gripping the club, and he is very comfortable just hitting the golf ball with one arm. So a variety of classifications exist, and they can be unique to each sport. So for example, with EDGA, we have impairment categories as well as sport classes or sport bands. So here's a screenshot from our little assessment tool where we go through each patient, doing a physical exam and taking a history and seeing what impairments do they present with, and where do they uh, qualify or classify in terms of the different areas of impairments. So if someone has specific range of motion deficits and strength deficits, then they may be more towards the orthopedic side or musculoskeletal side. But if they show different forms or levels of like hypertonicity or ataxia, then they would be placed towards the neurological impairment category. But it's being or having an impairment that meets a certain threshold that qualifies a patient to be placed or categorized in a certain category. So if someone just has like ankle dorsiflexion weakness at a 4 out of 5 or a 3 plus out of 5, and that's it, then they wouldn't meet that threshold for that musculoskeletal impairment category. But if they have multiple deficits throughout the limb that causes them to or affects their golf swing or the way they play the game, then that would um, increase their chances of being that threshold to be part of that category. So the different types of impairments are listed here. So you can have impaired muscle power, impaired range of motion, a limb deficiency, a leg length discrepancy, short stature, hypertonicity, ataxia, athetosis, a visual impairment, or an intellectual impairment. But the big things that we're looking for when we're evaluating these athletes are, do they have an eligible impairment for this specific sport? Does the athlete's impairment meet the minimum criteria or the threshold for that sport? And then which class, which sport class, do they should they be placed in for each sport? And what that sport class or sport band that you might hear is that level of impairment. So I believe for the upcoming Paralympics in LA, um, the sport bands, at least for golf, I don't know if it's been proposed yet or if it's going to happen yet for golf, but each country gets to have a certain number of athletes in each sport band, and each sport band is just the level of impairment that each athlete has. So it could be a mild to moderate to severe, um, and you get a certain number of athletes in each of those bands. So that's another way to differentiate golfers or athletes who have a more mild impairment where they still qualify versus those that have more severe impairments. A good example of this would be vision impairment, that there are some uh, vision impairment golfers who can still see out of one eye or things are blurry versus those that have complete loss of sight. So we know there are a lot of benefits in sport participation, um, and that goes the same for adaptive sport participation. A couple studies show that there is a significant correlation in sport participation as well as employment for our adaptive athlete population. And then there's also an improved self-belief, self-perception, sense of community, and all that is due to returning to being an athlete and being able to participate in sport. You can see here in this little chart that there are a lot of barriers to someone participating in sport, into adaptive sport. And I like this little chart because it just shows some different strategies that you can implement or that they can implement to overcome that barrier to break into starting to participate in adaptive sport. So we'll transition into just going over some injury and reviewing injury in adaptive sport. And we'll first take a look at this study that investigated it. So this study was out of 2019, and they looked at the past Olympic Games prior to 2019. And what they found was that there was a similar injury proportion between male and female adaptive athletes, that there is a high rate of injury with 5v5 football. There's a high rate at the Winter Olympics in Sochi, and they attributed that to possibly poor snow quality because I think they had to kind of fake some of that snow and bring it in because it wasn't that cold in Russia. A lot of the illnesses were affecting the respiratory system, and then for the most part, it was the shoulder that was the most commonly affected in those three Paralympic Games. Another study out of 2019 just looked at the self-reported injuries in non-elite adaptive athletes. So think not our Paralympians that uh, were. What this table is showing us is just the injury history of the population that these investigators looked at, as well as the medical care support that they utilize in the with their injuries. The big thing that my little red box shows is that although it's a small sample size, that prior to having an injury, there was no type of prehab or injury prevention that was utilized by these athletes. Um, but that injury prevention was still high even after the injury. So for our able-bodied population, I think it's pretty accepted that, yeah, injury prevention is a thing, even before having an injury, like especially with a running population. But it seems like with our non-elite adaptive athletes, that's not really a thing. And it could be the same with our recreational athletes that we work with. It could be just time or not wanting to do it, but still an area of growth that we can push with our adaptive athlete population. And then another consideration to think about is that a lot of our adaptive athletes don't know really who to turn to um, when they do have an injury, especially those that aren't really like a traumatic injury where they've stayed at a rehab hospital, have worked with physiatrists. Really, they just might be winging it and not really trusting whoever they go to. So that can be a barrier for them to even seek medical care. I know with the rock climbing population, that's a big thing, is that oftentimes climbers don't seek medical care because they don't think that their medical provider, whether it is their physician or PT, will know how to handle that specific injury. So improving uh, the education of working with adaptive athletes in the medical field and healthcare field is a big thing, but also encouraging our adaptive population, our adaptive sport population, to seek medical care before and after an injury is something that we can push. This table just shows the different body regions that were injured in this population for a 1 year period. And what you can see is that really wheelchair basketball is probably the roughest sport out there of the ones that they looked at, just because of the different areas of the body that were kind of affected. It could be just because that wheelchair basketball may be a little bit more aggressive with less protective equipment. And working sled hockey, wheelchair basketball, and wheelchair rugby, definitely seeing a lot more people laying out due to collisions in wheelchair basketball. So it could just be the nature of that sport. All right, so this study looked at factors that we can implement to reduce injury risk in adaptive sport through injury prevention programs. I believe this was 2024. Yeah, 2024. So they just did a big review, and found really with their results that injury prevention is pretty scarce and limited in terms of what's out there. And really, there needs to be more research. And not to say that it won't work, it's just that it hasn't been investigated thoroughly, and it's a hole in the literature that is primed to be filled by whoever wants to lead it. So future opportunities here for those who are interested in it. So now let's turn to some considerations for the adaptive athlete. This was a big, or this is a really good study that kind of outlined the different considerations um, that need to be thought of and planned for this population. So a good resource for you to utilize if you're ever working an event and need some refreshers in terms of what you need to think about. So first, this is their little algorithm on how to triage your able-bodied individual. And I know it's pretty small, probably on your screen, but it's your pretty standard triaging uh, algorithm for an on-field injury. Are they unresponsive? What are their vitals like? Is there an altered mental status? So on and so forth. But what it does do is have a little adaptive athlete section just to kind of point you that, yeah, let's look at this adaptive athlete algorithm, which is right here. So I'll let you go through this on your own, but it basically kind of helps direct you on um, what are the big considerations you need to make based off of this person's injury or condition, and helps you think about what are the big things you need to know right in that moment. So this first slide kind of shows the big three of considerations that you have to make with this population. The first one is acute altered mental status. So those with some type of central nervous system injury, hearing impairment, vision impairment, or some type of neurodiversity, meaning somewhere on the spectrum or um, some other conditions, that you may not know what their specific baseline is, and it may not be evident at the time of injury when you're stepping up to assist them. So having a gauge of the population that you're working with before an event, and then knowing either through um, the event information or specific individuals, whether it's family or coaches or teammates, on what that specific athlete's baseline is super important to know, because that may alter your decision if this person does have altered mental status or not. The next consideration is cardiac arrest, and uh, the big signs are that sudden drop in terms of uh, um, movement. So if they're on the field, like for able-bodied individuals, that there is that sudden drop where they just are on the ground without any apparent reason or injury, and they're just kind of flaccid and unconscious. Where for wheelchair users, especially those that are kind of strapped in, if they have that higher level spinal cord injury, that fall may not be evident, and then you might just see them kind of slumped over in a chair or in like this resting position in a chair, so it might not be obvious. So again, knowing your population and what their usual baseline is, as well as understanding that for our wheelchair population, that this is a big thing that may look different from the usual signs from someone that is moving around. Vitals are a huge thing to check if you're suspecting cardiac arrest in this population, just to know, yeah, are they uh, kind of um, is this something cardiac related going on or not? And then getting them supine is a big priority. And then for hypo and hyperthermia, a lot of individuals can have impaired thermoregulation, especially if they have spinal cord injury affecting their autonomic nervous system. They may not have the right or awareness of their limb temperatures due to sensation or body awareness. And they also might have increased risk for autonomic dysreflexia uh, and hyperthermia because of that higher level thoracic spinal cord injury. So again, knowing your population that you're working with from uh, before that event starts is very useful and vital to know for these conditions. Those with spinal cord injuries also carry the risk or the increased risk of orthostatic hypotension, um, especially since there's decreased autonomic nervous system activity below that injury level. Um, those with a visual impairment just have a higher risk for a lower extremity injury. Those with neuro impairment have a high risk for both upper extremity and lower extremity injury. And then wheelchair athletes have a higher risk for rotator cuff injuries, as well as some neuropathies of the upper extremity, just because of the positions that they put themselves in. Osteoporosis is a common thing or a common condition with spinal cord injuries. And we often see a 50% decline in bone mass 10 years post injury, just because they're not loading through those structures enough. And with that, there is an increased risk of fracture, even with more minor trauma. And then with seated athletes, there's an increased risk of skin and soft tissue injuries just because of the positions that they're in, especially when they're participating in sport with the increased pressure and demand on those structures that they're placing. And then with any prosthetic user, if there isn't a good fit um, and that prosthesis is moving a lot and twisting a lot with whatever movement they have to do, then that increases that risk of a soft tissue or skin injury. But even if it does fit well, and it's just a time-based thing, and they're not used to being on that prosthesis for that long, that also carries a risk for a soft tissue injury. Exercise-associated collapse can be a tricky one, especially with our seated athletes, just because, yeah, in wheelchair users or seated athletes, especially those with a higher level SCI and they're kind of strapped into a chair, that collapse isn't evident. So when we're suspecting this, just like with cardiac arrest, obtaining vitals is really important, just because if someone is experiencing um, uh, exercise-associated collapse, the initial treatment is to get them down into the Trendelenburg position with their legs up or feet up in the air above their head and heart. But that is actually the opposite move you want to make if someone is experiencing autonomic dysreflexia, where in that case you want them to be sitting. So monitoring those vitals and then seeing how they are affected with these different positions is key to know if you're doing the right thing for that individual. So we mentioned autonomic dysreflexia a few times, but yeah, this is a very uh, uh, concerning condition, especially those with high-level thoracic spinal cord injuries, just because you're getting this uncontrolled sympathetic discharge, which results in high blood pressure, increased load in the cardiovascular system, and then in really extreme cases, increase your chance of mortality. So this can be caused by bladder distension, tight clothing or equipment, constipation, fracture, pregnancy, or hemorrhoids, just different things that can kind of stress that sympathetic nervous system and cause it to um, really start to discharge at an uncontrollable level. Um, what this also does, because it increases the activity of the cardiovascular system, it can happen unintentionally, but often it's been looked at and has been seen to occur intentionally to improve athletic performance uh, in certain adaptive athlete populations. So when we're thinking autonomic dysreflexia, what we want to look for is anxiety, dread, or worry, just like an anxious person. If someone has some bladder or bowel distension, if they haven't used the bathroom in a while, they're starting to get blurry vision, widened pupils, they're lightheaded, dizzy, they fainted, they have fever, goosebumps, or flushed skin, especially only above the level of the spinal cord injury. If they're sweating profusely, if they have high blood pressure, irregular heartbeat, having spasms, nasal congestion, or a headache, all big signs of autonomic dysreflexia. And what you want to do is, if that person has a high blood pressure, you want to sit them up. If they're supine or on the ground, you want to make sure that they don't have any constriction on them from clothing or equipment. We want to make sure they're keeping an eye on their blood pressure as well as their pulse. And then we want to check for any other things that may be causing or propagating the episode of autonomic dysreflexia. So yeah, boosting is that intentional triggering of the autonomic dysreflexia response. So this study was released in 2015 by Mazzio. And first off, boosting was banned by the International Paralympic Committee. Those with high-level SCIs have that impaired sympathetic response to exercise and activity, so they have a reduced cardiac output, and which leads to reduced muscular endurance. So when that autonomic dysreflexia response happens, you get increased sympathetic activity, increased sympathetic nervous system activity, which results in elevated blood pressure, heart rate, and therefore cardiac output. And then you get improved muscular endurance and muscular performance. But then you also have these risks of hypertension, aneurysm, cerebral hemorrhage, stroke, and then death. So just like any performance enhancing drug or technique, yeah, you get this short-term benefit, but it leads to this short-term and long-term risk for these athletes. So something you want to be wary of, especially those from those with a spinal cord injury. There's a lot of different technology utilized in adaptive sport. We have our basic prosthetic. We have our more advanced prosthetics with microprocessors in them that assist with when the knee or the ankle joint bends and when it locks based on the gait cycle. And then you get specific prosthetics that have or that are specifically made for certain sports that replicate and possibly uh, work better than or advance how a normal like lower extremity would work. For seated individuals, you have different types of seating. So the individual on the left, he's using your standard motorized scooter where the seat turns, and he is free to swing that golf club. Where the one on the right is a little more advanced, where it kind of gets you a little bit higher in a golfing position. But it does that because this person most likely has a higher level injury where he requires more assistance. So the big debate is that because certain sports have uh, different levels of equipment based on that individual that's using it, that they all are designed to enable participation and performance. What is the line between being a device being a performance enabler versus a performance enhancer? One of the big things that I had to do as a medical assessor for EDGA and with the USGA was kind of look at the different prostheses being used to determine, does this give an advantage over those that are using quote unquote more normal prosthesis? And sometimes it's a tough call because, yeah, all of these devices help this individual perform a sport. Sometimes these devices um, assist in a way that outperform normal prosthesis or normal limb. So ensuring that it's doing the job to allow participation without giving anybody an extreme edge is can be a tough call and something to think about. Now, let's transition to the seated athlete. So this is a good resource and study that helps lay out the different factors that we have to consider when configuring a wheelchair for our seated athletes. So here you can see the different factors from the wheelchair user that we have to think about. So their height, their body mass, the different limb lengths that they have, what type of aerobic or physical fitness baseline that they're working with, their gender, their specific impairments, how skilled they are, as well as their age. And then from the wheelchair side, what materials that we want to use, their seating position, the camber, wheel size, and then the mechanics of the user um, that we need to implement on that chair. Because all of those, when combined together, require a certain demand on that individual and the chair. Um, Different types of muscle activity and muscle groups that we have to consider, how that user feels about that chair, and that all leads to their performance with whatever sport that they're uh, wanting to participate in. So here are some different components of a wheelchair. So for the more athletic chair, the big things that we have to consider are the camber or the angle that the wheels are set at. Um, uh, Compared to our normal wheelchair, they're not vertical. There's an angle to them, and that helps with how quickly and agile the athlete can be. The amount of bucket there is to the seat. That seat bucket dictates how much control that person has to utilize or may not have to utilize based on their impairment, because it kind of holds them in their seat. So those with more trunk control may not need as much of an angle to their seat bucket as those with less trunk control. And then the backrest width and height is to kind of determine, again, how much trunk control does that individual have. And then the last piece are the different straps that may be needed, again, based off of that control of that individual. So if you're not familiar with wheelchairs and working with the more sport-oriented chairs, this is a good picture and reference to fall back on when you do have to maybe give some input on that chair design, chair type for that athlete. So now let's look at this study that looked at the different risk factors for the development of shoulder pain in elite sled hockey players. Now, if you've never participated in sled hockey, if you ever get the chance to, you should, because it is super fun, but also the challenge is an experience to really experience for yourself. Not only having to coordinate two sticks in each hand, balancing yourself on that sled, but also having to maneuver around the ice, around people, looking for the puck, trying to get in certain positions. It's a very unique experience that puts a lot of different demands on the body. Um, what they found in this research was that the factors associated with shoulder pain, that over 70% of the population they worked with experienced shoulder pain in the last month. Um, and that heavy weight, as well as long duration of wheelchair use, was a big factor. Older individuals was another big factor, just those that have had to utilize a wheelchair or a plate slot hockey more, as well as lumbar spinal cord injury, just because they have that lack of trunk control. Interestingly enough, that sled hockey participation in itself was not a factor in determining shoulder pain. Just having to use a wheelchair for a long time, being older, as well as having that lumbar SCI. Alright, now let's transition to a little refresher on the lower extremity prosthetic. So first, we'll look at a study that looked at the rehab and long-term outcomes of people with trauma-related amputations. So the first thing to look at is that it's mostly males that are white, that are in their early to mid 30s that are sustaining these injuries. You think of those having midlife crises, getting a motorcycle, um, and then that most of these injuries are transtibial, so below that knee where it's occurring. Here they show the different scores with the SF36 between the general population, which is the top line, compared to individuals with trauma-related amputations. And you can see, obviously, there's some differences between the physical aspects of these two populations with physical functioning, physical role, bodily pain. But once we get to general health, vitality, social functioning, emotional roles, and mental health, that they all start to converge on each other. So just because someone has a trauma-related amputation doesn't necessarily mean that the social and self-perception aspects and mental health aspects are different. That really it's just that physical difference that is the big uh, differentiator between the two populations. This is looking at where do people go after that final amputation level is achieved. And you can see that for home, um, that for the most part, half the people that get a traumatic amputation um, go home, whether it's the foot, transtibial, the knee, uh, transfemoral, a bilateral amputation, or one that hasn't been defined. And that for transfemoral population, that a larger number will go to a rehab facility versus going home. But if you're having a bilateral amputation, that there is a greater percentage where death is on the table just because it's a more involved procedure and leads to uh, larger impairments. This table is just looking at the problems that people experience with their residual and contralateral limbs after going through a trauma-related amputation. And that, yeah, problems with the residual limb are expected. So things like phantom pain, constant pain, occasional pain, wounds and sores, those are all the common things that you'll experience. But oftentimes we can forget about the contralateral limb, where they found complaints of circulation, pain in those joints, muscle cramping, sores and wounds, numbness and weakness, and then a bunch of other problems that can occur in the contralateral limb. So we always have to consider the amount of load that goes into that contralateral limb as a compensation. And then in terms of work for this population, most individuals that go through a traumatic amputation get back to work or at least interviewing. But I think the big difference is that that demanding job percentage, although a lot of this population didn't have a demanding job before, it's going to be tougher to go back to a demanding job post-injury. All right, so now here's some resources that I provided you for through my time at Shirley Ryan Ability Lab, and this is one of the courses that I sat in on. That was a good refresher for how the lower extremity prosthesis works, what considerations we have to think about, as well as what adjustments we can assist with as PTs to either collaborate with the patient or with that patient's prosthetist um, to improve how they're moving, whether it is just through everyday life or through their specific sport of choice. So some general concepts for the transtibial prosthesis. The socket should fit pretty closely and intimately to that residual limb, just so we can reduce the forces that are going on it. Um, if we have too much force on that residual limb, that can result in skin breakdown. So of course we want to minimize that. And then the socket alignment should be aligned in a way that we're not only reducing force on that limb, but we're also maximizing gait efficiency and optimization. So we have different types of sockets that can be utilized for individuals. They can be a locking gel liner with a pin um, that goes into the prosthesis. We can have a socket that's a cushioned gel with a sealing sleeve, so more air suction. Instead of a sealing sleeve, you can use a ring to create that suction. And then you can use an actual vacuum to help create that suction. And how do you choose? It's mostly on that individual, what they have to get back to, and the skill of that individual to don and doff that prosthesis themselves. So some concepts to think about for the transfemoral prosthesis is that it should contour the muscles that are going to be present and working right then and there, as well as for those that will still be working in the future because they're going to grow just because of the increased demand. That it should stabilize that skeletal structure that it's going to be surrounding and supporting. That there is even distribution of pressure over any neurovascular bundles that are going to be compressed or affected, and that we're distributing that force over a large surface area because there's going to be a lot of weight and as well as more demand on those areas since there's less joints to work with in terms of gait. So there are a variety of different sockets out there for transfemoral prosthesis. You can have a quadrilateral socket, which has four well-defined walls, a rectangular shape, and then is weight bearing through the ischium and the glutes. You can have an ischial containment where it kind of captures that ischium. That femur is held in an adducted position. It's a lot closer and intimate fitting socket and has this more triangular shape. So now going back to transtibial prosthesis, the different things we have to think about in the sagittal plane during gait are that through that loading response, we want to control knee flexion. So we really want to make sure the quads and glutes are activated during that stage. Through mid stance, it's all about making sure that knee is stable. So again, quads and glutes. And then in late stance, we want to make sure we're advancing over the tibia, which requires those glutes to fire. You can see the different factors in the prosthesis that matter. So for us, it's making sure that we're getting this not only sufficient strength of these muscles, but also the timing and activation of them through the gait cycle. So in that coronal plane, we want to make sure that that individual is able to control their base of support. You can think of like a newborn baby trying to walk, that they're nice and wide with their uh, uh, base of support because it creates stability. But our goal is to be able to normalize or optimize gait with a more narrow base of support. We want to make sure that there isn't a varus thrust, or that we're controlling that varus thrust, that outward shift of the prosthesis, the socket, during weight acceptance, and that at mid stance that there is a vertical pylon, that metal part of that prosthesis. We want to make sure that we're normalizing that weight shift side to side during gait, and that we have the correct prosthesis height so there isn't any type of changes in terms of their frontal plane motion. For the transfemoral prosthesis, we want to make sure that the distribution, that plumb line in terms of where that patient's weight is over that limb is kind of centered, and that it allows that limb to function properly. So if that socket is a little too forward and that center of mass line is crossing anterior to the knee and ankle joint, then they're going to have a tough time of unlocking that knee. Whereas if it's more posterior and we're in a more flexion moment for the knee, it'll be a little too unstable. So we want to make sure we're optimizing that, as well as being able to relay this information to their prosthetist to make these adjustments at their next follow-up. You can see in this picture that that socket is angled in such a way that to be able to get that patient's foot on the ground, that knee joint is flexed. So the alignment of the socket needs to be positioned in a way to create that stability of that limb while also allowing for mobility when that patient wants to be mobile. So for transfemoral injuries and amputations, oftentimes we want a little bit of a hip flexion contracture um, for how that socket is going to be fitted. Um, you can see in the before picture that there's that the end of that socket is positioned right over that knee joint, which causes him to stand in a flexed knee position. Where in the after picture, that socket where it's inserting into the knee joint, they moved it a little bit more anterior, so that knee is a little bit more posterior, so that way that they can stand in a natural position without having to be kind of flexed through that hip. In terms of knee control, with that transfemoral prosthetic, um, we don't have quads in these individuals, so that hip extension is crucial to be able to control the knee. So like in the previous slide, the position of the socket relative to the knee is super important to allow for that passive stability in standing. But then when we're actually moving, we need to ensure that those hip extensors are firing as best they can, but also the alignment of the prosthesis can impact how much or how little that the patient has to rely on those hip extensors, those glutes. The funny thing about having that hip flexion contracture on how we want that is that we know that if there are some restrictions in the hip flexor length or contractile force, that kind of feeds into that antagonist inhibition response where those glutes don't fire enough. So it's kind of a balance act between these two of uh, the mobility of that hip joint to allow for a proper flexed hip position, but still able to allow for hip extensor activity. So for the sagittal plane, here are the different factors that we need to think about for the transfemoral prosthesis. Loading response, our goal is to get that knee fully extended. So we need those hip extensors to be able to work, as well as enough core stability to optimize glute activation. At mid stance, we want to maintain that knee in extension. So again, those glutes need to be firing. And then at late stance, we want to initiate that knee flexion, which we do through our hip flexors. We want to make sure that that patient can coordinate all of those actions through this whole gait cycle. So the big thing, again, I've said it multiple times already for the past couple of slides, is that hip extensors are key for the transfemoral prosthetic user. If they're weak, we can have excessive knee flexion or buckling during gait or in stance. We can have an anterior trunk lean to compensate. We can have reduced step length, and we can have a very slow gait. So ensuring that we're really working on glute strength, glute activation, and glute neuromuscular control is essential to normalize gait for our transfemoral prosthetic users. So for the frontal plane, the really challenging part is to be able to control that socket and stabilize that socket around that residual limb. Ischial containment was one of the types of sockets that were used, and it utilizes these contact points at the ischial tuberosity to create a rotational torque to be able to stabilize that socket around that residual limb. When it doesn't work well, you can see some specific compensations, such as like a lateral trunk lean to one side, so that involves side, or an abducted gait, so that limb's like kind of sticking outwards because either the prosthesis isn't fitting well, it's moving around, or there's just a lack of control. So things to look out for when you're watching a transfemoral user, especially from that frontal plane. Here is a list of deviations in stance for our transtibial prosthesis users that you can kind of look out for. And then our next slide here are a list of deviations during swing for the transtibial users. Here are some stance phase deviations for our transfemoral users. And then here are some deviations during swing for transfemoral users. So the big thing to remember is that you're physical therapists, you're not prosthetists. But with your background, your TPT training, your residency training, you can kind of deduce something's up with the gait. Is it a prosthesis error, or is it a user error? Is it a strength issue, a neuromuscular control issue, or is it a fit issue? And then think about kind of what are the demands of gait, and then what are this specific patient's uh, what are their gait requirements? What do I have to worry about? And most of the time, when you're thinking about that, you can kind of deduce what needs to be changed. So having a good relationship with certain prosthetists in your area can not only assist with helping these patients out with quicker fixes, but also it can help with kind of your knowledge base on what you need to look out for and different things you can adjust yourself before they have to go to that prosthetist. All right, we're going to transition to adaptive golf for a little bit. So this study looked at how the golf swing was affected in individuals with lower limb amputations or lower limb loss. And what they differentiated was between if someone had a lead limb amputation versus a trail limb amputation and how that affected the golf swing. So they had about 13 participants with varying types of amputations from the foot through the tibia through the femur. And they occurred through trauma, infection, vascularization, as well as cancer. So what this chart shows is the ability to weight shift in individuals with lower limb loss. So our first chart, the top chart A, is looking at those with a lower limb amputation versus, or a lead limb amputation versus a trail limb amputation, and looked at the weight shift between their lead and trail leg, so the amount of pressure between the two at that specific point of the golf swing. And what they found was that there was a significant difference in those with a lead limb amputation versus a trail limb amputation at impact and follow through. So at those 2 points, impact and follow through, we are striking the golf ball and shifting our weight from our back foot towards our front foot. So it kind of makes sense that those with a trail limb amputation did this much better compared to those with lead limb amputations because those individuals are going from that involved side to their uninvolved side, side that's probably stronger, has more proprioception and kinesthesia, and the more comfortable side for those users compared to those with a lead limb amputation where they're going towards that prosthesis side, that prosthetic side. The second chart here just shows the weight shift comparison between above knee amputees as well as below knee amputees. And what you can see is that the below knee amputees did better in terms of their weight shift at transition compared to those with an above knee amputation, meaning there was a larger gap between lead and trail limb compared to the above knee amputees 60-40 versus 20-80. So this just kind of demonstrates that those with a below knee amputation can transition or shift their weight a little bit better during the golf swing, which kind of also makes sense that those individuals with a below knee amputation, again, have more joints intact, more muscles intact, and more sensory nerves and just more things intact versus their above knee counterparts. So what this table shows is the differences in X factor between lead limb and trail limb amputees. So what X factor is the separation between the pelvis and the thorax or the chest at the top of your backswing. So better golfers have more of an X factor compared to worse golfers. So you compare Rory McIlroy to myself, he's gonna have like 10 or 20 more degrees than me. And again, he's one of the best strikers of the golf ball in the world. So what this chart is showing is that those with a lead limb amputation um, can generate a larger X factor compared to those with a trail limb amputation. And how this works is because it's at the top of our backswing, and we're bringing that weight to our trail limb, those with a prosthesis on that trail limb or a limb loss on that trail limb maybe aren't as comfortable getting to that side, which is why they may not generate a larger X factor compared to those with a lead limb amputation. So again, just to know, or the thing to think about is that the side that that prosthetic is on, regardless if we're talking about weight shift or X factor or anything else, is that it's gonna change or affect the way someone does whatever activity they're doing. So the things that can affect adaptive golfers and affect their swing are how well that prosthesis, that's prosthetic fits, um, that residual limb's range of motion, that residual limb, their static and dynamic balance on it, and then the confidence that they have while loading up that involved side. So our final piece here is return to sport for the adaptive athlete. We'll start off with this article right here, which showed off or which discussed um, dysvascular amputations and kind of what happened to these individuals after they went home. So you can kind of see the flow chart of this patient population from where they started from on the left to where they were discharged to after they had their amputation to where they were at 1 year post. And there is a difference between those that had a traumatic amputation versus a vascular amputation. Those with a vascular amputation, generally they have a lower health profile, a lower activity profile, and are just less healthy compared to those um, with traumatic amputations. So for the most part, outcomes are lower in that dysvascularized population. So you can see that they were discharged after their surgery to a variety of different places, and that 1 year after, there was 31% of them that died that were discharged after their surgery. So here is the some characteristics of the patient population that was sampled, as well as the analysis. So in this first, or the second and third columns, you can see the comparison between those that did go home versus those that didn't go home after surgery. And that, for the most part, the older population weren't able to return home after surgery, that 75 to 84-year-old range. And then a large chunk of these individuals that did undergo surgery were between 55 to 75 years old. At the bottom here, we can also see their discharge destination, that there's a good mix of individuals that went to inpatient rehab and skilled nursing that did eventually go home. But those that didn't go home were discharged or were at skilled nursing facilities as well as nursing homes. And then the ones that did go home, over 76% of them did get a prosthesis, where the individuals that didn't return home, almost half of them did not get a prosthesis. So a big difference in um, how much function these individuals have based off of if they are able to return home or not. All right, now that we looked at where do certain individuals after an amputation go after surgery, let's look at this little study that looked at how to improve gaits. So the things to consider for a patient that has um, amputation in their future, if you see them beforehand, are what can you do um, beforehand in terms of how prepped they are for surgery, in terms of the challenges that they will face, the rehab that they'll go through, and especially that prosthesis fitting process, because that's a process in and of itself. It takes a while for that residual limb or that stump to take its final form. And then how physical therapy will progress throughout that healing process, because they're going to use a variety of assistive devices for ambulation initially, and then having to kind of progress in terms of the devices they use, from a walker or wheelchair to a wheelchair to a quad cane to a single point cane to no device, and then how much support that they're going to get through that gait training process with double limb upper extremity support, single limb upper extremity support, no support at all, from no contact guard or from total dependence to no assist at all from a therapist or caregiver. So these guys looked at the different phases of gait by putting sensors on both involved and uninvolved side to check a variety of parameters during the gait cycle for lower extremity prosthetic users. And basically, what they found was that there are a bunch of different strategies that individuals utilize when they're using a prosthesis, in terms of how do they clear the foot, not only involved but uninvolved side, the actions of heel strike, midfoot strike, toe strike, um, step length, cadence, pressure between both sides, or time on each side. So it's our job as PTs to really get a good read on how an individual is walking with their prosthesis, what are the factors causing them to display any deviations that we're seeing, and then what can we do to improve that gait. Here's a study that looked at walking characteristics of runners that utilize a transfemoral or knee disc articulation prosthesis, so midway through the femur, or disc articulation at the knee. And basically what they found was that um, during walking gait, these individuals utilized their intact limb more versus that prosthetic side, and that's kind of the trend that we've seen throughout this whole talk. And specifically, that intact limb or uninvolved side plantar flexion and hip extensor moments are being more heavily relied upon for the gait cycle. So some good considerations when you're training someone with transfemoral prosthesis. So lastly, last thing we'll talk about is return to sport with a lower extremity prosthetic. The big thing is that there's not a lot of stuff out there on this topic right now. So a few years ago when I did my lit review for this, these are the big things that I found: that there's some return to driving, return to surfing, return to running, different CRACE reports and cross-sectional studies. And of course, there are a lot of studies on gait and ambulation for prosthetic users, but really nothing on return to sport. So a lot of limited evidence, and again, we just need more research to investigate these topics. One of our sports scientists at UIC, I've discussed this a lot with her. Her research is primarily with uh, prosthetic users, transtibial and transfemoral, is that because there's such limited evidence, not only with just ADLs, uh, with gait and walking, that there are a lot of different gaps in between gait and then specific sport that need to be filled before we can even think about return to sport for the lower extremity prosthetic users. So this is a topic you're interested in. There's a lot of opportunities for research out there in this field. So in conclusion, adaptive sport participation improves the prognosis um, of these people in this population. There's a lot of different sports out there and adaptive athletes out there, but it's really our basic knowledge of the sport as well as how individual moves, even the able-bodied individual moves, that helps us support this population. There are specific special considerations for the adaptive athlete, especially as a emergency responder. So please be sure to utilize that one resource I gave you to refamiliarize yourself with those specific considerations. We need to have some basis of knowledge um, on how these pieces of technology, whether it's a prosthesis that's quote unquote dumb or smarter with computer chips, um, we need to have a basis of how they work to help optimize how that individual returns to sport and participates in sport. Um, Not a lot of return to sport data out there, so further investigation is needed, but we can still utilize the research on able-bodied individuals out there, as well as our knowledge of those that utilize a wheelchair or those that use the prosthesis or any other condition to help guide our decisions on how we work with these specific patient populations. But really, our physical therapy approach doesn't change. That we have to have a good baseline knowledge, a foundational knowledge. We have to have great clinical reasoning skills, and then we have to be able to be uh, adaptive and innovative with how we treat these patients. Here are a list of references, and then yeah, um, this is the first time I've done this talk async, so it's always different when you're not interacting with the crowd. But I appreciate you listening to this recording. If you have any questions, feel free to email me. Um, there's my UIC email right there. And then, yeah, happy to respond or chat to address any questions, concerns that you have about adaptive sport.